Namaste bacho. Welcome. So today we are going to talk about something you will see every single day in your clinics. Constipation and diarrhea. I'm telling you, this is your bread and butter. If you master this, you'll be a great doctor. So, notes ready? Let's get started.
Okay, so here's the plan for today. First, we'll tackle the full stop problem, constipation. Then we'll see how to get things moving with purgatives. After that, we flip completely to the other side, diarrhea. What's the pathophysiology? Then the most important part, the lifesaver, rehydration. And finally, we'll look at the drugs to slow things down. It's a lot, I know, but we'll get through it. Let's go!
Right, Section 1, Constipation, the full stop problem. And listen to the subtitle, Bacho, Understanding the Causes Before Reaching for the Prescription Pad. This is so important. Before you even think of writing a prescription, you have to be a good clinician. Constipation is just a symptom, it's not the disease itself. So your first job is to play detective, figure out what's really going on with the patient.
So, first things first, what is even normal? You'll be surprised how many patients have this all wrong. They think they must go every single day. So please, this is a key part of your job. You have to counsel them. Tell them, look, normal can be anything from 3 times a day to 3 times a week. It's a huge range and it's different for everyone. This one conversation can solve so much anxiety.
And 99% of the time, what's the cause? It's the simple stuff. It's the lifestyle. Not enough fiber in the diet, not drinking enough water, a sedentary job where you're just sitting all day long. And the big one, rushing in the morning and ignoring that natural urge. These are the culprits. I'm telling you, for most of your patients, just fixing these things will solve the problem. No medicine needed.
Okay, now this is interesting. You have to understand that not all constipation is created equal. On one hand, you have spastic constipation. Think irritable bowel syndrome. The gut is tense, it's cramping, the stools are like little stones. If you give a stimulant here, you'll make it so much worse. Here, you need soluble fiber, like a spigula. On the other hand, you have the atonic, or lazy bowel, common in old age. Here, the gut is just sluggish. You'll try lifestyle changes first, of course, but maybe you'll need something like lactulose. See? You can't treat a tense gut and a lazy gut the same way, It's totally different.
All right, Section 2, Getting Things Moving. So what happens when all that lifestyle advice just isn't cutting it? Well, that's when we open up our pharmacology toolkit and look at the purgatives. First up, we have the gentle approach. This is for when you want a soft, formed stool, and you're not in a hurry. It takes 1 to 3 days. Think of bulk-forming agents or docusates. These are perfect for mild cases, or say after a surgery when you really don't want the patient to stray. Okay, what if you need something a little stronger? Something that works overnight, maybe in about 6 to 8 hours. That's when you reach for drugs like bisacodyl or senna. These will give you a semi-fluid stool, a bit more action for more immediate relief.
And then, you have the situations where you need to clear everything out, and fast. We're talking 1 to 3 hours. Think about preparing a patient for a colonoscopy. This is when you bring out the big guns, the saline purgatives. They'll produce a complete, watery evacuation.
So look at this table. This is your best friend. Seriously. Don't just blindly memorize it. Understand it. On the left, you have the gentle, slow-acting agents. In the middle, the overnight ones. And on the right, the fast-acting ones for complete clean-out. The clinical situation, the patient's need, that is what dictates your choice. It's all about matching the drug to the job. Now listen to me very carefully, Bacho. This is a serious warning. You will meet patients who are obsessed, completely obsessed, with having a bowel movement every single day. They get hooked on these stimulant purgatives. And what happens? The bowel becomes lazy, it becomes dependent, this is purgative abuse, and once this habit forms, it is so difficult to break. You must counsel your patients against this. Okay. Let's switch gears completely. We've talked about when things are too slow. Now, Section 3, diarrhea. What happens when things are moving way too fast? What is actually going on inside the gut? Why is so much water being lost? If you understand the why, the treatment becomes logical. Okay, look closely at this diagram. It's the whole story in one picture. You have 2 main players here. The villus cells, on top, they are the absorbers. Their job is to pull in salt and water. Simple. Then you have the crypt cells, down below. They are the secretors. Their job is to push out chloride and fluid. In a normal, healthy gut, there's a beautiful balance between the two. Absorb, secrete. Absorb, secrete. Perfect.
So what do the bad guys do? How do bugs like cholera cause such a mess? It's like a hostile takeover of your gut. Their toxins come in and they flick a switch. They tell the villus cells stop absorbing, and they tell the crypt cells secrete like crazy. So what's the result? You've inhibited absorption and stimulated secretion. Your gut, which is supposed to be an absorptive organ, turns into a secretory organ, just pouring out liters and liters of salt and water. It's a disaster.
Okay, section 4, the lifesaver, rehydration therapy. Given that massive loss of salt and water we just talked about, what do you think is the single most important thing to do? Before you even think about an antibiotic, before any other drug, what is it? It's rehydration, just replacing what was lost. This simple thing, Butcho, is what saves lives. Never ever forget this.
Ah, this one. This is a classic Viva question, so pay attention. Why did the WHO change the ORS formula? Look here. The old formula was from 1984. Its osmolarity was 310, slightly higher than the body's. The new formula from 2002 has an osmolarity of 245. It's a low osmolarity formula. And there's a very, very good reason for this change.
So why is the new one so much better? Well, look at this. It actually reduces the stool volume by 20%. It reduces vomiting by 30%. Because it's less concentrated, water gets absorbed faster. And crucially, you don't have the risk of hypernatremia or high sodium, which is super important in children. So the point is, it's not just a small change. The new formula is actively better at treating diarrhea.
I want you to look at this number, 13. 13 children die from diarrhea every hour in India. Let that sink in. This is why what we are talking about today is not just some academic exercise. This is real life. Knowing how to manage diarrhea, knowing how to use ORS properly, it's not just a skill, it's a life-saving responsibility that you will carry.
All right, section 5, slowing the flow. So let's be very clear. Once the patient is rehydrated, once they are stable, only then can we start thinking about other drugs. And even then, we have to be extremely careful and rational about what we choose. So this is our armamentarium, our toolkit for diarrhea. You can see we have different categories. We have antimicrobials for specific bugs, we have probiotics, and then we have the non-specific drugs that we'll focus on. These just treat the symptoms. Now, before you even think about prescribing a drug, you have to answer this question. Is it non-invasive or invasive diarrhea? Non-invasive is watery, high volume, maybe some cramps, but usually no fever. Think cholera. Invasive is different. It's smaller volume, but there's mucus, there's blood, there's fever. The bug is actually attacking the gut wall. You have to know the difference because the treatment is completely different. Here's a good one to remember. Resveratrol. This is a pure anti-secretory drug. It doesn't affect motility at all. It just goes to those overactive crypt cells and says, hey, calm down, stop secreting so much fluid. And because it doesn't slow the gut down, it's considered very safe, even in children. A great option for that watery, secretory diarrhea. And then there's loperamide. This is probably the one you've all heard of. It's an anti-motility drug. Basically, it slows the whole gut down. By increasing the transit time, it gives the intestines more of a chance to absorb water back. It works very well for symptom relief in adults. But, and this is a huge but. So when is loperamide dangerous? If there's one thing you remember from today, let it be this. You must never, I repeat, never, give an anti-motility drug like loperamide if you suspect invasive diarrhea. If there is fever, if there is blood in the stool, do not give it. Why? Think about it. You are trapping the bad bugs inside. The body is trying to flush them out, and you are stopping it. This can lead to a disaster, things like toxic megacolon, where the gut just balloons up and can even perforate. So what is the final word, the golden rule? First, rehydrate. Second, diagnose. And only then, if it is simple, non-invasive diarrhea, can you think about treating the symptom. Your first job always is to do no harm. Cello students, let's begin. Today we are going to tackle a very important topic, antimicrobial drugs. And we'll do it in a smart way. We'll start with a real clinical case, inflammatory bowel disease, and from there we'll learn the general principles, the main funda. So, let's get started. Right, so here's our game plan for today. First, we'll look at the drugs for IBD. Then, we'll take a step back and see the history of antimicrobials. After that, we'll learn how to classify our weapons, understand what we're working with. Then comes the big one. What happens when these microbes fight back? And finally, we'll talk about the risks of friendly fire, a proper high-yield session.
Okay, first section. Imagine you are in your clinic. You're dealing with IBD, and you know this means both ulcerative colitis and Crohn's disease. Believe me, this is a challenge you will face day in and day out. So let's understand the strategy.
Socho, just think about it. Your patient is suffering, their gut is literally on fire with all that inflammation. What are you going to do? What are the weapons you have in your medical toolkit? This is where having a clear, step-by-step strategy is everything.
Now look here, this is the IBD treatment ladder. This is a very, very important concept for your clinical rotations. We don't just throw all the medicines at the patient at once. No, we climb the ladder. We start with step 1, 5 ASA compounds for local action. If that's not enough, we go to step 2, corticosteroids for the big flare-ups. Still not working? Then we go to step 3, immunosuppressants. And for the really tough cases, the reserve drug is at step 4, TNF-alpha inhibitors. Remember this step-up approach. It's crucial.
So we just saw a specific case. But where did all these powerful drugs come from in the first place? To really appreciate our modern medicine cabinet, we need to look back a little. Look at the history and at the giants on whose shoulders we are standing today.
First, let's clear up a basic concept. When you hear the word chemotherapy, you probably think of cancer, right? But its original meaning is much bigger. Chemotherapy is all about selective toxicity. You want a drug that is a magic bullet, one that kills the infecting germ without hurting the patient. Attack the doucheman, but leave our own soldiers alone. This is the main funda behind every single antimicrobial drug.
And what a story it is. Look at this timeline. From Ehrlich in 1909 to Domik in 35, and then boom, penicillin in 41, and streptomycin from soil microbes in 44. It was a golden age of discovery. It was amazing, but it also made us a bit careless. We thought we'd always have a new drug for any bug. And that thinking led to overuse, a problem we are still paying a heavy price for today.
Okay, so we have this whole arsenal of drugs now. But just having weapons is not enough, right? We need to know how to organize them, how to classify them. Understanding how each drug actually fights its battle is the key to using them properly.
So basically, there are two main attack strategies. Bacteriostatic drugs, they are like the police. They just stop the bacteria from multiplying, they arrest them, and then our body's own immune system comes and clears them out. But bactericidal drugs, they are like the Army's special forces. They go in and directly kill the bacteria. This is a classic Viva question. PACA, they will ask you this, so mark this point. Static versus cytal.
And this diagram shows how they do it. It's like a military strategy. You see, some drugs attack the cell wall. That's like breaking down the enemy's fort walls. Others target protein synthesis. Basically, you jam their factories so they can't make anything. And some drugs go after the DNA function. You corrupt their blueprints, their battle plans. Every class of drug has its own unique way of attacking the enemy.
Right, so we have all these powerful weapons. It sounds great, but there's a problem. The enemy is not stupid. The enemy is smart. They fight back. And this brings us to probably the biggest single challenge you will face as doctors, the huge, critical problem of drug resistance.
It's a question you really have to think about. We have penicillin, we have fluoroquinolones, we have so many powerful drugs. We have won so many battles. So why? Why are we still seeing infections that are so difficult, sometimes even impossible to treat? Well, the answer is because the enemy can adapt.
Now, the main issue is not natural resistance. Some bacteria were always tough. The real clinical problem is acquired resistance. This is when a microbe that used to be easy to kill, that was sensitive to our drug, learns how to survive our attacks. And why does it learn? Because of our own use of these drugs over time.
So how do they do it? Two main ways. First is mutation. This is slow. A bacterium gets a random genetic change that helps it survive, and it passes it down to its children. That's vertical transfer. But the really dangerous one, the scary one, is gene transfer. This is like bacteria sharing cheat codes with each other. One resistant bacterium can just pass its resistance gene to its neighbor. This is horizontal transfer, and it's why resistance can spread like wildfire through a hospital.
Now listen carefully. As future doctors, this is on you. This is your responsibility. The fight against resistance starts in your clinic. Step 1, and this is the most important, do not use antibiotics indiscriminately. I'm begging you, no antibiotics for a simple viral cold. Step 2, whenever you can, use a narrow-spectrum drug, a specific weapon for a specific enemy. And Step 3, for long fights like TB, always use combinations of drugs to hit the enemy from multiple sides.
Okay, last section for today. Even when our drugs work perfectly, even when they kill the right bacteria, they're not without risk. Sometimes, even when we hit the target, there's collateral damage. We can call it friendly fire.
You need to know about 3 main types of this friendly fire. First is toxicity. This is predictable damage to organs. It's dose-related. Second is hypersensitivity. This is an unpredictable allergic reaction. And third is superinfection. And this is a big one. This happens when our antibiotic is so strong it kills the bad guys, but it also kills all the good bacteria in our gut, our normal flora.
And when all the good bacteria are gone, what happens? The door is left wide open for a new, often much tougher organism to come in and take over. A classic example is getting a candida infection after taking a course of broad-spectrum antibiotics, so the very drug we use to cure one infection ends up causing another one. This is a huge risk, especially with broad-spectrum drugs and in patients whose immunity is already weak.
And so we will end with this question. This war against microbes, it is not static. The enemy is constantly changing, constantly evolving, constantly finding new ways to defeat us. So the crucial point for you, as the next generation of doctors, is to understand that our strategies must also constantly evolve. We have to be smarter, we have to be more precise, and we have to be more responsible than ever before. I want you to think about that.